Now, a small number of people are going to have Zollinger-Ellison syndrome causing their ulcer disease. A small number of people, less than 1%, a small number of people will have Zollinger-Ellison syndrome causing their ulcer disease, less than 1%. Now, Zollinger-Ellison syndrome is diagnosed by both an increased gastrin and an increased gastric acid output. It has to be both of these things. Both of these things for Zollinger-Ellison syndrome. Oh! A 48-year-old video producer has himself a duodenal ulcer. He gets put on a proton pump inhibitor. The Helicobacter serology is elevated. The biopsy shows that he's got Helicobacter pylori. He gets put on a proton pump inhibitor, amoxicillin and clarithromycin. And he is found to have an elevated gastrin level. What do you do next in the management of this patient? The answer is two things. Remeasure the gastrin level off the proton pump inhibitors, or measure the gastric acid output. Everybody on an H2 blocker and everybody on a proton pump inhibitor is going to have an elevated gastric acid output. That is natural. The same way that everybody who has, let's see, thyroid stimulating hormone causes your thyroid hormone to make T4 and T3. T4 and T3 should go back and have feedback inhibition on your pituitary. The only way to have both an elevation of your thyroid hormone and an elevation of your TSH is to have a TSH-producing tumor, a TSH-oma, a TSH-producing tumor. So therefore, the only way to have an elevated gastrin level and an elevated acid output is to have a gastrinoma. Now that gastrinoma is Zollinger-Ellison syndrome. Everybody on an H2 blocker is gonna have elevated gastrin. That's natural. Acid is the major inhibitor of gastrin release. Acid and somatostatin are the two major inhibitors. Secretin does a little. Secretin, as you know, as the acid goes out of your stomach, from your pyloric sphincter, as the acid goes out of your stomach, when acid goes in here, whoop, 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 dial 911, and the acid should cause the release from your friend and mine, the pancreas, should cause the release of secretin. Secretin should cause the pancreas to release bicarbonate as well as pancreatic enzymes. Secretin should cause the release of bicarbonate. Acid goes out here, secretin should be released from the duodenal cells, and bicarbonate should be released into the duodenum to neutralize that acid. Therefore, secretin should also decrease gastrin. Secretin goes to the pancreas and promotes bicarb release. Secretin also should go to the stomach and decrease gastrin. That's why if you have secretin, and secretin either causes no change or an increased gastrin, that's also Zollinger-Ellison syndrome. Now, everybody on an H2 blocker or proton pump inhibitor has an elevated gastrin. You have to do one of two things. Stop the anti-secretory therapy and measure the gastrin, or measure the gastric acid output. And that's how you confirm the Zollinger-Ellison syndrome. Now, once you know you have Zollinger-Ellison syndrome, if this was you, you would like to see that it's local and do surgery and cut that thing out of you. If it's metastatic disease, you can only treat it with lifelong proton pump inhibitors. So the question is, how do I make sure that my Zollinger-Ellison syndrome, my gastrinoma, is local? Well, I have to do tests to exclude the metastases. Well, how do I exclude metastases? The problem with ultrasound, CT, and MRI is that these are only somewhere between 60 to 80% sensitive. That means that if you do these tests, you're going to miss 20 to 40%. And if I miss 20 to 40% of my metastasis, if I operate on the local disease, you're going to die from metastatic disease that you don't see. Gastrinoma cells have the same calcium density as the local tissue. So the ultrasound, the CT is not going to see them. They have the same calcium density. MRI is based upon the content of water, and it has about the same water density. If you had a person who had a positive beta HCG and a negative pelvic ultrasound and a negative pelvic exam, what would you do next? Look and see if there was an ectopic inside you. If you had a positive prostate-specific antigen and negative examination, what would you do next to see if you had prostate cancer in there? If you have this positive elevated gastrin level and an elevated acid output, and your ultrasound, CT, MRI are negative, how would you tell if you had that gastrinoma? Well, if I'm looking for an ectopic pregnancy and my pelvic sonogram and my pelvic exam, I can't feel it, it's time to send flowers, chocolates, and take your sonographer for dinner and a movie, because it's time for a transvaginal ultrasound. Well, if you have an elevated prostate-specific antigen and I can't feel anything on the lobes of your prostate, well, it's time to send flowers and chocolates and take your sonographer to dinner and a movie, because it's time for a transrectal ultrasound to see if inside of you. Oh, wait a second, I recently had a new thought. I know everything you think. You don't have any new thoughts. You're boring and repetitious. No, I had a new thought last week. Where'd it go? Oh, my new thought. Yes, I have it right here. Yes, my new thought. I just remembered. I displaced it, but it's here. You have positive blood cultures. Ralph Waldo Emerson, in his essay on self-reliance, says the only real satisfaction comes from the triumph of principle. The only real satisfaction comes from the triumph of principle. Lao Tzu in the Tao Te Ching said, the man of Tao can know the whole world without having to look outside even his own window. Because if he comes to understanding a principle, it can be predicted. The man of Tao can understand the whole world without having to even look outside his window. Now, if you see all of this as four things, but I only see it as one thing, I am perfectly willing to accept the fact that you are twice as smart as me. I think you are. But if I see it as one thing and you see it as four things, you may be twice as smart as me, but you're not 4 times as smart as me. So if I only have to learn one thing and you got to learn 4 things, well, you're not 4 times smarter than me. If you have positive blood cultures, but a negative transthoracic echocardiogram, it's time to go down inside places in you that no one has been before. Transesophageal echo. Oh, I think you got an ectopic pregnancy. The pelvic sonogram and pelvic exam are negative. Transvaginal ultrasound, get that scope into you. Man, the sonographer is getting more action than I am, that's for sure. Hey, the prostate-specific antigen is elevated. The negative exam, I don't feel it. Transrectal ultrasound. Hey, you got a gastronoma. Where is it? I can't operate on you because I'm going to be an IP. Now, what do? Endoscopic ultrasound. Endoscopic ultrasound. The single most accurate test for the diagnosis of Zollinger-Ellison syndrome. The award goes to, why, thank you. The endoscopic ultrasound. Put the scope all the way inside with a sonogram machine on it, right into your pancreas, and put the scope right in here. And let's take a look around. The same way, it's like taking the transesophageal echo and moving forward another 2 feet through the stomach, through the duodenum, and it becomes an endoscopic ultrasound, looking around at your duodenum, at your pancreas, and the surrounding tissues. Now, the last part about this is, when should I think about Zollinger-Ellison syndrome? When the ulcers are large. Most ulcers are normally less than 1 centimeter. When the ulcers recur, 90% should get better with treating Helicobacter pylori. When the ulcers are distal in location, most ulcers are within 2 to 3 centimeters of the pylorus. When the ulcers are large, recurrent, distal, and multiple, most ulcers are single, less than 1 centimeter, and proximal to the pylorus. So therefore, if they're large, recurrent, distal, and multiple, larger, recurrent, and distal, and multiple, larger, recurrent, and distal, and multiple, time to go looking for the Zollinger-Ellison syndrome. The last thing is, when should you go looking for men? When should you go looking for men? 1, when you have time. 2, when there's hypercalcemia. When do you go looking for men? Come on, say it out there. Say it out there. Don't pay attention to the people in the videotape next to you. Don't pay attention there next to you. Repeat after me. All the women out now out loud. When should I go looking for men? When there's hypercalcemia. Hypercalcemia from the hyperparathyroidism. When do I go looking for Zollinger-Ellison syndrome? Although most of the tumors are still, ulcers are less than 1 centimeter, large ulcers, I should looking for ZE. Or recurrent, or distal, or multiple. Lions and tigers and bears, oh my. Large and recurrent and distal and multiple. Large and recurrent and distal and multiple. That's when I should go looking for my Zollinger-Ellison. Now, ultrasound, CT, and MRI are not as accurate. There's a nuclear somatostatin receptor scintigraphy. There's a nuclear somatostatin scan, but it's not as accurate as endoscopic ultrasound. Nuclear somatostatin receptor scintigraphy is not as accurate as a endoscopic ultrasound. Another of the diagnostic tests for Zollinger-Ellison syndrome is the nuclear somatostatin scan. Now, the nuclear somatostatin scan is a test that is more accurate than the CT, the ultrasound, or the MRI, and it has to do with the fact that patients with Zollinger-Ellison syndrome have somatostatin receptors expressed in increased amounts. Now, this test of the nuclear somatostatin receptor scintigraphy, a very long word, basically means that people with ZE syndrome will show metastatic disease if you have technetium-labeled somatostatin and inject it in, and it will home into and attach to those somatostatin receptors, and it has to do with the fact that patients with Zollinger-Ellison syndrome express somatostatin receptors in increased amounts. However, the somatostatin scan is not as sensitive nor as specific as endoscopic ultrasound. So you say, when do I answer it? Well, what if they say, which of the following is the most accurate diagnostic test, but endoscopic ultrasound is not one of the choices? Part of the difficulty of preparing for any standardized test is that we think we know what the choices will be. And the problem is we don't always know what the choices will be. Sometimes we have to choose the answer that may not be the best test, but the best test that's listed in the choices. Ultrasound is not the best. CT, MRI, X-ray is not the best. If nuclear somatostatin is all that's there, that's the answer. If endoscopic ultrasound is there, that's definitely the single most accurate test. Now, what we have shown here is that people who have epigastric pain cannot easily be diagnosed. People with epigastric discomfort cannot easily be distinguished one from another. And that is because the symptom is very vague and nonspecific. That is because many people, for reasons that are unclear, psychological, emotional, bad luck, spite, retained resentment against my mother, may have epigastric discomfort, and the precise mechanism is just not clear. We do know statistically that only 10 to 15% of people have ulcer disease for every 100 people presenting with reflux disease. The same way, if we thought about chest pain, people coming to the emergency department with chest pain, 50% have no heart disease whatsoever. And only 10% have a myocardial infarction. Another 10% have unstable angina, also referred to as other acute coronary artery syndromes. So it's the same concept that most of the time people come with epigastric or chest pain don't actually have definite documentable disease.